Welcome everyone to Cardiology Grand Rounds. We're delighted to have Dr. King, who Dr. Connie Stow will be introducing. Thank you for your patience with our format of the slides. Dr. King and I have been working to troubleshoot them, and I think this is the most clear format that we've come up with. So hopefully everyone can see the main slide well enough. So Connie, go ahead.
Okay, wonderful. Hopefully everybody can hear me. So I have the wonderful pleasure of introducing our guest speaker today, who is Dr. George King. He is, among many roles, Professor of Medicine and Ophthalmology at Harvard Medical School and Chief Scientific Officer at the Joslin Diabetes Center. His CV is quite difficult to summarize in just a few minutes, and the highlights that I'm going to follow will really only encompass a fraction of his impressive decades of work, actually. Dr. King earned his bachelor's degree from Johns Hopkins University and his MD from Duke University. Following medicine residency at the University of Washington, he spent several years as a researcher and clinical associate in diabetes at the NIH and NIDDK. He then came to Boston, where he began research at the Joslin Diabetes Center during his early appointment as faculty at the Brigham and the prior Deaconess Hospital. Over the next years to 2 decades, he rapidly rose to section head of the Vascular Cell Biology Division and director of Diabetes and Endocrine Research Center at the Joslin, as well as full professor at HMS. 20 years ago, he was appointed to director of research at Joslin and subsequently senior vice president and then chief scientific officer. He is a leader of many professional societies, including past chair of the American Diabetes Association, and has served on countless foundations and NIH grant committees, and is on the editorial board of several prominent journals. He is the recipient of numerous national and international awards, including the Edwin Bierman Award from the American Diabetes Association, Mary Tyler Moore and Robert S. Levine Award for Scientific Clinical Research from the Juvenile Diabetes Foundation, and has received numerous grants from the NIH beginning back in 1985, including translational work investigating mechanisms of insulin action on vascular tissue, on which he may speak today. He is also the founder of the Medalist Study, which is a longitudinal study of individuals with decades of type 1 diabetes, through which I've had the pleasure of working with him to describe cardiovascular structure and functional correlates of this unique cohort. And finally, Dr. King has been very active promoting education to the Asian American community and is director of the Asian American Diabetes Initiative at the Joslin. He has published over 300 manuscripts, reviews, and book chapters, and mentored nearly as many trainees over the past 2 decades. I may exaggerate, but I lost count actually when reviewing his CV. I could go on with his accomplishments, but in short, we are very fortunate to have him with us today to teach us more about diabetes and the mechanisms of insulin and insulin resistance in CVD. Thank you, Dr. King, and please go ahead.
Yes, thank you, Connie, for inviting me, and thank you for the cardiology division for giving me this opportunity to share our work. I'm assuming people could hear me. I'm still, even after 2 years, I'm still not totally with it on this presentation. So I apologize for the smallness of the screen. I hope it works for. So anyway, this is also my first meeting with my new Department of Medicine. This is, we just, as of January 1st, have the research department have now joined the Department of Medicine at BIDMC, so we're very excited. So today, I'm speaking about diabetes and cardiovascular disease and the role of insulin resistance, and I'll mention a little bit at the end how we are now collaborating with Connie and also Alan Hamden of the Vascular Surgery Department at BIDMC on a new project, which fortunately just got funded from NIDDK and NIHLB. So the, this is what I was, let me see. It doesn't, okay, so conflict is noticed here. The key points, I think we already been sent around to people, but we're going to focus on diabetes and CVD and a little bit discussion of the differences between type 1 and type 2. First, I just want to talk about diabetic complications, which affects many organs in the body. Today, we're going to focus on cardiovascular disease, but I just want to mention two new ones that's really coming on and making people very nervous about it, and that is cognitive dysfunction. Turn out now, Alzheimer's disease in this country, about 15% of the Alzheimer's are related to diabetes, probably both type 1 and type 2, and neoplastic disease, especially GI cancers, also about 15-20% due to diabetes. But today we're going to focus on cardiovascular disease. So the good news is that the diabetic complications, especially with cardiovascular disease, such as MIs, strokes, amputations, are decreasing. The incidence is shown here in a New England Journal review a few years ago. The mortality rate for both type 1, type 2, and cardiovascular disease are also decreasing, as shown here in another paper. So I think it's a very good news. And that's probably due to all the wonderful prevention and new treatments that we have for cardiovascular disease. The risk factors for diabetic complications, for some of the complications shown here, the most complex one is the cardiovascular disease, as shown with many risk factors, whereas retinopathy, neuropathy is mainly hyperglycemia, where nephropathy have multiple other ones. So the cardiovascular disease have many risk factors, but today I'm just going to focus on two of them. One is the hyperglycemia and insulin resistance, the next one. So it's shown here that in type 1 study, it's called the EDIC and DCCT study, where they look at the conventional treatment versus the intervention, that intensive intervention, that is very clear that after 5 to 10 years of intensive treatment, that cardiovascular risk is decreased in type 1. And similarly in type 2, that there are now beginning evidence that intensive care may be helpful, as shown here, of odds ratio of 0.85. But type 2 is a little less certain because there's some studies actually have shown increased mortality, there's increased risk of hypoglycemia, and so forth. So it's very clear in type 1, type 2 is likely. Now we have a lot of new drugs now. I know this is, the cardiologists have been incredibly helpful in bringing these about, such as the SGLT2 inhibitor turned out to be very, very helpful in lowering cardiovascular diseases, improve outcomes, but this turned out to be also important for people without diabetes. This is mainly used for type 2 diabetes because it does increase ketones in the blood, which increase ketoacidosis risk in people with type 1 diabetes. In addition, there's a GLP agonist. It's also available now, which also lower cardiovascular risk in most of the studies summarized here. Now, one thing about these studies is looks like is the effect is fairly fast. So for example, in the SGLT2 inhibitor, you could see the improvement outcome in 3 to 6 months. So the thought is that these improvements are mainly due to myocardium, heart failures, and efficiencies. So today I'm going to spend most of our time on insulin resistance or as a risk factor. And if you compare type 1 and type 2 mortality, you could see that for both male and female that the risk starts about 30 years and of age compared to the Framingham as well. But these patients with type 1 diabetes essentially develop their disease below age of 20. So the risk for cardiovascular disease does not occur until after the onset of type 1 diabetes. However, for type 2 diabetes, is great data for Andrew Koleski. This is from 1991, but has been replicated multiple times now. Now, for type 2 diabetes, if you look at the bottom beginning of follow-up, which is really only 2 or 3 years after the onset of diabetes, the risks already have occurred. So the belief and thought is that the insulin resistance that's already occurring in pre-diabetes, where with hemoglobin A1C usually around 6 to 6.3, that the insulin resistance that predates the onset of diabetes give risks for people with type 2 diabetes. So that's different from type 1 diabetes. So there are multiple pathologies in cardiovascular system, and there are in diabetic patients such as endothelial dysfunction, accelerated atherosclerosis, restenosis, cardiomyopathy, poor collateral vessel formation, and fibrosis. Today, I'm just going to focus on atherosclerosis, endothelial dysfunction, and restenosis. So it's been discussed for 50, 60 years now. The question, are insulin's effect on cardiovascular tissue anti or pro-atherogenic? I think this is questions is becoming clear that insulin, most of insulin's action is actually protective. There was a very large study comparing long-acting insulin and the cardiovascular disease called the Origins trial, which did not show any significant increases of risk for cardiovascular parameters. There is one on new onset of angina, but the rest is pretty much negative. So in general, clinical studies have not supported insulin to be a pro-atherogenic action. So clearly, atherosclerosis affects multiple cell types, as shown in a beautiful review here by Ira Tabas a few years ago. But today, I'm just going to focus on insulin's action on endothelial cells and smooth muscle cells. It turned out that insulin has large number of actions on vascular wall. And as you'll see here that I'm a little small, I apologize, that it can have effect on vascular permeability, on endothelial cells, vascular tone on smooth muscle cells, angiogenesis, anti-inflammatory actions, which I'll show you in a minute, and that I won't have time to show you today. And that's very exciting new finding that Dr. Park, who has gave me the slide in our lab, junior faculty in our lab, we'll have a paper soon to show that insulin actually on the endothelial cell through nitric oxide can increase the development of brown fat, and in turn can actually have anti-atherogenic actions in addition to whole body bioenergetics. So keep the weight down in these animals that he has produced. Certainly has vascular smooth muscle cell actions and platelet and thrombosis, which I won't have time to discuss. So turn out insulin has lots of actions and the direct actions on the endothelial cells and smooth muscle cells. So I'm just going to share a few of them with you today. And in general, insulin, which again, sorry about the small size of the slide, that insulin affects endothelial cells, as in blue here, and has merit of signaling and can actually affect VCAM, ICAM. And it also, insulin, once you get past the endothelial cell barrier, have actions on the smooth muscle cells, which I'll show you a little bit about today that again, I don't have time. So the thinking about diabetic complications have also changed in the last 10 to 15 years. And previously, it's always thought that the complications of diabetes is due to metabolic abnormalities, hyperglycemia, free fatty acids, causes what we call toxic factor or causal factors such as AGEs, oxidative stress, ROS, angiotensin inflammation, protein kinase C activation, then leads to vascular complications. Due to a lot of reasons, and mainly due to the fact interactions or interventions to inhibit these agents have not been the responses have not been very good. So recently, there's been a huge change, and that is that the importance of the protective, endogenous protective factors, which usually can neutralize these toxic factors induced by diabetes. However, hyperglycemia and other things can actually inhibit the action of these factors that are listed here. One classic example is obviously antioxidant enzymes, which I won't have time to discuss again. But today we're going to focus on insulin as a potential endogenous protective factor. So over the last 20, 25 years, our lab and now many lab start to study the insulin actions on first we did it on endothelial cells, now with smooth muscle cells. So insulin action, just like any other cells, we shown a long time ago now in the 1980s, have structurally insulin receptors very similar to with other cells. Again, it also mediates its action through two major pathways. And today I'm going to focus mainly on the actions on RS1, 2, PI3 kinase, AKT, which leads to a whole host of actions in both endothelial cells and smooth muscle cells, which we think in general is anti-atherogenic. Now, this part of the action is usually inhibited in diabetes, whereas the other pathway, which is generally causes proliferation and migration, may potentially have a role on either pro-atherogenic or intimal hyperplasia, which I'll briefly show you some data. Another aspect on insulin action on vascular cells is unusual, is it's a real problem clinically and therapeutically. It's because it has a divergent vascular actions, especially on angiogenesis, as shown here. So in the retina, we know that there's increased neovascularization in severe diabetic retinopathy, as shown picture here. And in 1990, our lab showed that the major reason for the increased angiogenesis and severe PDR, proliferative retinopathy, is due to increased levels of VEGF. And now that has the major treatment for diabetic retinopathy is now using an anti-VEGF antibodies. Now, in the myocardium, both in animal and in human, there's actually decreased angiogenesis or decreased collateral vessel formation, and turn out they have decreased VEGF. So in the same animal, diabetic animal, and the same patient, you could have opposite reaction of tissues, and that leads therapeutically difficult. And this is one of our paper from a long time ago, 2002, and shown that in diabetic people in control, those with heart disease and those with diabetes, there's decreased VEGF. It's not just VEGF, but also the VEGF receptor expression in the tissues in the myocardium are decreased with respect to VEGF expression. And one reason for that is that insulin can actually stimulate VEGF expression in the myocardium. This is data again from multiple publications from our laboratory, and show the concept of selective insulin resistance. So if you look at insulin's action on phospho-AKT activation in the cardiomyocyte, in the lean, insulin stimulated very nicely, but in the fatty rats, that's actually decreased. And if you look at ERK, which is the other pathway I mentioned earlier, there's really no difference between lean and fatty rats. So there's a selective inhibition of the AKT pathway. And through a whole host of study, Henry Hay, who's now practicing in Cambridge, that insulin stimulation of VEGF in the cardiomyocyte is impaired in these fatty rats, and this all have been reproduced by others. Now, this is not our data, but Christian Madsen, who was a faculty at Joslin and from Denmark, when he was in Denmark as a fellow, and multiple other groups have shown that insulin can enhance endothelial dilation in the human forearm, and through beautiful work by multiple group, this looks like is increased NO, and through insulin's activation, AKT to phospho-enos. So the theory then that is that the selective insulin resistance in the vascular cells, that's due to diabetes or obesity, and due to the presence of inflammatory cytokines, fatty acid, or hyperglycemia, that could cause something. I won't have time today to activate a whole host of stress kinases like PKC, and they will selectively inhibit insulin signaling through this pathway and causes insulin resistance. And through multiple studies now, this is from Chris Madsen, when he was here at Joslin, to really prove this, that he essentially knocked out insulin receptor in the endothelial cell only. And what he showed is that the lipid deposition in these ApoE mice with insulin receptor knockout, they have increased lipid deposition. And the atherosclerosis is much worse when the insulin receptor is removed from the endothelium in these mice. And so what is the mechanism? One potential mechanism that Christian showed is that insulin can actually regulate VCAM in the endothelial cells. And so normally, insulin will decrease the inflammatory protein VCAM in the endothelial cells and then increase atherosclerosis. But if you, as shown here, that if you look at the expression of VCAM protein in the endothelial cells, that they will decrease. And if you use L-name, that will reverse some of these effects. So if the theory is that the insulin receptor on the endothelial cells is important for anti-atherogenic actions, since we remove insulin receptor and that actually increase the then if we increase the expression of RS1, then that should decrease atherosclerosis. This is the work done by Min Park, who, again, I mentioned earlier, is a junior faculty at Joslin. And the reason RS1 is important because it's actually the signaling molecule that mediate insulin receptors action. And this was discovered by Dr. Ron Kahn and Morris White in the 1980s, and then mediate its actions. And we think it will activate AKT, eNOS, increase the NO, and then decrease atherosclerosis. So Min did a series of studies. It's actually quite difficult back in the before the CRISPR days, that you essentially have to either overexpress or knock out one of these proteins, and then because only ApoE or LDL receptor knockout, mice will have significant atherosclerosis. They have become bred to derive these mice. As shown here, that he was successful to increase the RS1 protein or mRNA here, as well as the protein using a VE cadherin promoter. And then he introduced these ApoE or RS1 ApoE mice to either high fat or very high fat diet. And this is actually something interesting, that in the ApoE mice, mostly used by cardiovascular research, usually use Western diet, which is about 40% diet as shown here. But if 42% diet, I'm sorry, the high fat diet, which tend to cause severe insulin resistance, is what needed actually to cause severe insulin resistance. In most mice, usually 40 to 50% of fat was more than enough to cause severe insulin resistance. For some reason, ApoE mice require 60% of high fat diet to do that, as shown here. The plasma insulin levels is barely increased on 40%, 42% diet, but 60% really increased the insulin resistance. And the RS1 signaling in the endothelial cells is also increased and improved with RS1 overexpression. And I hope you can see this, that when imaging, did beautiful work on imaging, on the increase of NO production in endothelial cells in culture, in wild type cells, and in RS1 overexpressed endothelial cells from ApoE mice. Clearly could show there's an increase in NO production from the endothelial cells. And when he looked at the atherosclerosis, I just look at lipid staining. There clearly is an increase with increasing amount of fat, but in the mice that have increased RS1 or improved insulin sensitivity, the severity of the atherosclerosis lipid deposition is decreased. And further, we also looked at the complexity of the atherosclerosis. So it's also decreased from trichrome staining, which is mainly extracellular matrix or collagen, and smooth muscle cells decreased, and macrophages decreased. So almost all the models of diabetes, whether you have increase or decrease with diabetes, you will see an increase in smooth muscle cell, extracellular matrix, and macrophages. And when you intervene you'll see all these parameters to be improved. And so it doesn't really address the question of stability. So I'll address that in a minute. Now, as we mentioned earlier, that most of the studies our focus have been on insulin action on the endothelial cells. And I showed earlier that the anti-atherogenic action through the AKT pathway, and this is lost in insulin resistance or diabetic state. And that's been confirmed both in human tissues as well as in animal tissue with diabetes. And I showed earlier that the effect on endos is that insulin can actually decrease VCAM. So if you inhibit that, there'll be increase, and insulin could activate eNOS and decrease atherosclerosis through this pathway. I didn't have time to show you that insulin have antioxidant effect by increasing the expression of HO1 as well. But let's now switch the discussion more to smooth muscle cells. And the topic will be focused mostly on restenosis, and then we'll switch back to atherosclerosis as well. Now, in restenosis, the main player is actually smooth muscle cells, even though other cells do play some role, but they're fairly minor in comparison with the atherosclerotic plaque, which obviously has many players, as we mentioned earlier. So the treatment of the plaque, and I don't have to tell this group because you guys know more about it than I do, has been improving greatly, especially with the drug-eluting stents. However, if you compare people with diabetes with those people without diabetes, the restenosis rate is still higher in people with diabetes. And this is really a common phenomenon, let me stress again, in almost every aspect of treatment for cardiovascular disease is with every new treatment, improvement occurs, but for a reason it's not clear, and that's that almost every treatment, whether it's lipid, statins, coronary artery bypass surgery, stents, even now with SGLT2 inhibitors and so forth, the success rate, it definitely significantly improved, but the differences between people with or without diabetes is always maintained about twofold. And as shown here with the outcome with the stent therapy. So the traditional hypothesis ever since I was a fellow in the 1970s has been that one reason insulin and IGF is thought to be more pro-atherogenic is that it's believed that both insulin and IGF-1's signaling in vascular smooth muscle cells will promote the development of intimal hyperplasia due to their growth promoting activities I mentioned earlier, probably through the MAP kinase activation to accelerate arterial stenosis. So this is the hypothesis. And so Chan Lee in the laboratory, and we published this a couple of years ago, and to answer this question, how does insulin receptor in the smooth muscle cell affect intimal hyperplasia, and then I'll show you in a few minutes its effect on atherosclerosis. So what he found initially is that this is an intimal injury model on mice fed with a high-fat diet. I don't have time to show you that compared to with regular chow, mice with high-fat diet will have increased intimal hyperplasia. But comparing these wild-type mice on high-fat diet with the SMERCO or smooth muscle cell insulin receptor knockout mice, as shown here, that's how we tabulate the smooth muscle, the intimal thickening, and you can see that intimal area is much less compared to the wild type in the knockout mice, and in those with intimal and media ratio, it's also less. And although the media area itself has not changed, so it's mainly the intimal hyperplasia is decreased in the insulin receptor knockout. And what he also went on to show is that this is due to the proliferation of smooth muscle cell in the insulin receptor knockout mice. Again, I don't have time to go through in detail. But what was really, so that was to be expected according to the theory, but what we found and to be surprising was that the IGF-1 receptor knockout, insulin like growth factor 1 receptor knockout mice targeted to the smooth muscle cell actually have opposite finding. They have increased intimal hyperplasia, which is opposite to what we found in insulin receptor knockout. So the previous theories that both should do this, yet they actually have opposite finding. Insulin receptor knockout, we have decreased intimal hyperplasia due to proliferation. But when we have increased, when we knocked out IGF-1 receptor, the hyperplasia is actually increased. And he went on to do a series of studies, which I don't have time to go into detail. And this is our paper, Nature Communication 2019. This was actually, has like 50 or 60 figures and panels. And what he showed through a series of very elegant structural action analysis of the receptors show that in the wild type, there are insulin receptor, IGF-1 receptor, but there's also hybrid receptor of insulin and IGF-1. In this insulin receptor knockout, you have insulin, you only have a homozygous IGF-1 receptor, but in the IGF-1 receptor, you have homozygous insulin receptor. And again, through a large series of studies, he was able to prove that homozygous insulin receptor was more mitogenic than the hybrid receptor. So when you knocked out the insulin receptor, there's only homozygous IgF receptor, which is not as potent as mediating growth and proliferation as IGF-1 receptor. But recently, he just finished studies, and which is very, very, very exciting, is that in contrast, atherosclerosis was actually accelerated in this insulin receptor knockout ApoE mice versus ApoE mice in this. Remember, earlier I showed you in the same mice, restenosis was decreased, but atherosclerosis is actually increased. And then what it went on to show is that in these mice with increased severity of atherosclerosis, there's actually decrease in smooth muscle cell number, increase in macrophages, in proliferation. this Jialin Fu did this collaboration with us, with him. And the cap thickness and necrotic area in these atherosclerotic plaques in the ApoE versus insulin receptor knockout will also change with decreased thickness and increased necrotic area. So this is very exciting because this is really the first type 2 model of diabetes that we could show this unstable plaque. And this is commonly found in people with diabetes. And so this is, so our conclusion then is decreasing insulin action in smooth muscle cell in insulin resistant and diabetic state may reduce the risk for restenosis after angioplasty, but it may contribute to the formation of unstable atherosclerotic plaque. And we're very excited because finally we have a model, I think, in pathology mimic one of the major risk factor for MI and in people with diabetes. So I think I showed you some data. Hopefully you're partially convinced that insulin is an endogenous factor for most of the cardiovascular diseases other than restenosis in this sort of schema of toxic factor and protective factors regarding to diabetes. So in the last few slides, I do want to bring up our new area of study. This is, again, are there differences between type 1 and type 2 diabetes with regard to cardiovascular disease? And the new area that's, I think, really opening up is the role of autoimmunity. As I showed you through early on, that there are definitely differences between type 1 and type 2 from an insulin resistance point of view and onset of CVD. I don't have time to show you because there aren't a whole lot of data. Are there pathological, in pathology, are there differences between type 1 and type 2 diabetes? But just briefly mention autoimmunity. So this is beautiful work by Dr. Myra Lippis at Joslin, and who proposed that there is post-infarct autoimmunity, and due to one, there's a thymus lacking alpha myosin expression, then that will lead to escape pathogenic T cells. And then in myocardial infarction, there's necrosis and released cardiomyosin, and that leads to innate inflammation, migration of dendritic cells, autoimmune response, and leads to post-infarct autoimmunity. And she had a series of studies published recently in Circulation. And beautiful data, again, showing that autoantibodies are present in people with type 1 diabetes, MI, also those with myocarditis, and as opposed to type 2 diabetes, and people don't have diabetes, as shown in the myosin heavy chain autoantibodies. Now, recently in collaboration with Connie Zhao, we're very excited about, and now with Alan Hamden and at Vascular Surgery, we'll begin to a comprehensive analysis of people with type 1 diabetes and their cardiovascular clinical picture, imaging, and pathology. This is based on our medalist study, whose people who have at least 50 years of diabetes. We're giving out medals for 50 years of diabetes, 75, 80, and recently, most recently, we are just have a new medal. We have 2 or 3 patients now who are still alive and have had 85 years of type 1 diabetes. So their age is anywhere between 87 to 95. So then they brought to Joslin for a whole series of study. I don't have time to discuss. We are now starting eye disease, kidney diseases, and so forth. So the whole idea is that when we looked at their clinical picture, that they are very protected to the kidney disease, retinopathy. I don't have time again, about 40% of them don't, 45% of them don't have any retinopathy, nephropathy, or so they seems to be very protected to these two complications so far. And I don't have time to discuss. We actually went through a series of studies, identified we think are potential protective factors for the eye and for the kidney in a series of papers in Nature Medicine and Science Translational Medicine in the last 2 or 3 years. But today, I just want to give you an inkling that we actually are starting to look at cardiovascular disease. And this is work done by Mark Yu, who's still a clinical fellow in our group. And what he showed is that in this medalist study, 1,000 people cohort, they have very good glycemic control. Over the last 70 years, the A1C is only 7.1. And their lipid profile is really, really good with high HDL. Actually, the women with medalists have all with a HDL greater than 70. Their LDL is very well controlled, and it's really not, it's been studied by Karen Bornfeld in University of Washington, and they are really shown that incredibly good lipid. They have a low incidence of or prevalence of nephropathy, which is major risk factor for CVD. So, but it was surprised when Ron Blankstein at Brigham did the calcium score that what we show is not surprisingly that when you have low calcium score, you have low incidence of cardiovascular disease, which inversely correlated with increasing CAC score. But what was interesting in this really well controlled patient population, that they have very high CAC score, as shown here. This is the medalist population compared to the type 2 groups. They maybe even higher than the people with type 2 diabetes. So they're controlled by many other, by all the risk factors. They seem to be protected against small vessel disease in the eye, yet their calcium score are very high. So we are embarked on this new study. Thank goodness we got funded by NIHLB, who just started, NIDDK, collaborating with Ron Blankstein, the Brigham. Connie Chow is providing beautiful work on the imaging study on the CMR. And it turned out the CMR looks very good in these patients. So they seem to have very good myocardial function, but the calcium score I mentioned earlier was very high. And Alan Amden can provide us with vessels after surgery, because no one really has studied the pathology of cardiovascular pathology or atherosclerosis in the large vessel in type 1. The whole world literature is only 17 cases of pathology study. And then Andy Lichtman at the Brigham Pathology is going to be looking at all these cardiac vessels and coronary vessels and peripheral artery vessels with us to determine whether the T cells and B cells and other pathology are similar in type 1 and type 2 patients as well. So let me finish here and thank you for your attention. Again, apologize for displaying not in a great way. And certainly people in my laboratory, I mentioned many of their names in yellow already here. And this is our medalist stuff, medalist staff, and as well as all the funding agencies that's been supporting us over many years. It was Connie here. Again, I'm very excited to join the Department of Medicine at the BIDMC and our other collaborators. Thank you.
Thank you very much, Dr. King. That was really excellent. We have one question that's come in on the chat, and others, please feel free to send in questions or come off mute. So Dr. Joe Canham says, fantastic talk. In your mouse models of insulin resistance, you use high-fat diets. If you use high-carb, high glycemic index diets, do the mice develop the same amount of insulin resistance?
Well, we haven't really done that. And really with high carb diet, in the past, other people have tried it and have not really shown it can really increase or accelerate the severity of atherosclerosis lesions that much. But again, it has not been systemically studied in a big way. I guess it's possible that you could try high fructose diet, which has been shown to can increase the atherosclerosis. But high carb diet has not really done a great deal, because that will also increase, because these mice don't really have severe diabetes, so they will compensate by increased insulin secretion.
Thank you. Dr. King, I had a question about PI3 kinase inhibitors, which are increasingly being used for cancer, as you know, and can cause hyperglycemia, and whether you have any recommendations as far as how best to approach our patients who might have either baseline cardiovascular disease or cardiovascular risk factors who are good candidates for PI3 kinase inhibitors. Should we be co-treating them with SGLT2 inhibitors, for instance?
Well, I guess we can answer two ways. One is, I would suggest you could probably control them better with insulin, because insulin is decreased ketone production. So that will perhaps improve in a fundamental way. And insulin, as I mentioned earlier, have a great deal of action on the endothelium, on the NO production. So that would be very helpful. The inhibitor definitely has issues, but the SGLT2 inhibitor is action, as I mentioned, is mainly in the myocardium, and rather than the atherosclerosis. So it doesn't really have. We actually published a paper in animal model showing that SGLT2 inhibitors don't have much action on the development of atherosclerosis. So I think I would suggest insulin as a probably better intervention when you are treating patients with PI3 kinase and other inhibitors in cancer patients.
Thank you.
Can I ask a question?
Sure.
That was a great talk, and thank you for giving it this morning. So you showed a lot of nice work in mice studies or animal studies of the role of insulin in decreasing inflammation in endothelial cells. So how are these models able to differentiate type 1 and type 2?
Well, most of the model we have used are really in type 2 models. So you're asking a very, very important question. Now, STZ, streptozotocin model, which is a insulin deficiency model, is not really a type 1 model. We don't really have a true, at the moment, there's no real type 1 model that's in use, because in order to have type 1 model, you actually have to have autoimmunity, right? And not just insulin deficiency. So almost everybody using is that they get rid of the beta cells and you have insulin deficiency. So hopefully next time when you have me give me a talk again, we can talk about a true type 1 model, because Min Park, I mentioned earlier, has now developed a true type 1 model. What he did was took the NOD, which is a true type 1 autoimmune mice, and he actually knocked out ApoE in that mice using a CRISPR approach to see whether that model will also have increased insulin, increased atherosclerosis, which it does have. So we are now, that's part of our interest in this new study with heart and lung and with Connie, is how does autoimmunity affects that, and turn out, as well as what Myra showed, that there's increased myocardial antibodies, there seems to be increased number of different type of subset of T cells in the pathological lesions of these mice with ApoE, joint knockout of ApoE and NOD as well. So hopefully we could answer that question. In addition, we hope we could get more information with the collaboration with you now on the this really, I think it's going to be one of the best comprehensive study of type 1 diabetes and cardiovascular disease ever. I told you, we already submitted a manuscript, so you know about it since you're co-author, looking at the calcium score, the imaging, beautiful imaging study you all did, and the clinical feature and a whole host of clinical parameter. And in the next couple of years, we hope to have coronary vessels, peripheral leg vessels pathology, single cell analysis. So I think we're really looking for, oh yeah, I forgot metabolomic study that we just finished showing it's very different from type 1 and type 2s. So I think this whole area is going to be really opening up in the next 2 or 3 years.
Thank you, Dr. King. We'll take a final question from Dr. Dhruv Kazi, who asks, certain racial or ethnic groups, particularly South Asians, have a high level of insulin resistance. Is there a mechanistic explanation?
Well, that's another 3-hour discussion. Why does Asians, especially South Asian and Filipinos, have so much diabetes with a low BMI and have very high rate of CVD? And why does the Japanese and the East Asians, even though they have high insulin resistance and high insulin resistance and even similar lipid profile as the Americans, yet their MI seem to be much lower, but they have increased rate of strokes. There's definitely increased inflammatory cytokines. The South Asians and Filipino have high level of visceral fat. And again, you could say, why? Well, why do they have high rate of, I don't know. It's very true that Asians have high amount of visceral fat compared to the peripheral subcutaneous fat. And we actually don't. This is really a very, very important question that's really understudied, and we really don't know why.
All right. Well, thank you very much, Dr. King, for joining us on this snowy Boston morning. It was a pleasure to have you, and we really appreciate all your thoughts and the discussion. Thank you.
Okay. Thank you. Thank you for having me.
See everyone next week. Bye-bye.
Thank you. Bye-bye.